Great, thank you. And, thank you. And could you load the slides? Great, thanks. I'm going to start by providing a brief overview of these two Urban Institute surveys, which are the Health Reform Monitoring Survey, or what we call the HRMS, and the Wellbeing and Basic Needs Survey, or the WBNS. Then we'll present some key findings and tips for using the data that are available through ICPSR, and we'll conclude by discussing a few lessons learned and future work that we have planned. Next slide. So first, we're grateful to the Robert Wood Johnson Foundation for supporting both of these surveys. This work began with the launch of the HRMS in 2013 to explore the value of internet-based survey methods to provide timely data on the Affordable Care Act before data from federal surveys were available. And we used the HRMS to monitor changes in health insurance coverage and healthcare access following the implementation of the ACA's major insurance coverage provisions. And we also used it to collect data to inform key policy and implementation challenges, like setting up the new health insurance marketplaces. More recently, we've broadened our focus to include other topics, such as the pandemic, patient experiences with healthcare providers, and social determinants of health. And the HRMS also provided the template for our second survey, the WBNS, which we launched in 2017 to track people's well-being in anticipation of major changes to federal safety net programs. Although other surveys track measures of material hardship and well-being in isolation, the WBNS brings these various measures together in a single survey. And we also focus on participation and access barriers to major safety net programs like Medicaid and the Supplemental Nutrition Assistance Program, or SNAP. Next slide. So first, I'll provide an overview of the design of both surveys. Next. So both the HRMS and WBNS are nationally representative, internet-based cross-sectional surveys of adults ages 18 to 64. And we focus on non-elderly adults because they and their families are the ones who are most likely to be affected by the Affordable Care Act and the safety net policy changes that we're studying. Now, it's important to note that because this is an online household survey that's conducted in English and Spanish, we don't cover all adults in this age group. So the samples are missing adults who are in institutional settings or group quarters, as well as people who are homeless, who don't speak English or Spanish, or who have low literacy levels. Currently, each round of the HRMS has a sample size of about 9,000 adults, and the WBNS has a sample of about 7,500. Next slide. In terms of timing and frequency, the HRMS originally started as a quarterly survey between 2013 and 2015. We then shifted to a semi-annual schedule with each round fielded in March and September until 2020. After the 2020 HRMS, we conducted 2 follow-up tracking surveys with a subset of those respondents to monitor the impact of the pandemic. And now we're fielding the HRMS on an annual schedule, with the most recent round occurring in April 2021. One key advantage of the HRMS is that we have the ability to release estimates on a very quick turnaround. So most federal surveys have a lag of 6 months to a year between when they collect the data and when they first publish results. With HRMS, we're able to publish estimates within weeks to a couple months of data collection. And the WBNS also provides rapid results on a similar timetable and is fielded annually in December. Next slide. So for both surveys, we draw stratified random samples from the Knowledge Panel, which is managed by Ipsos. This is the nation's largest probability-based online panel with about 55,000 members. And it includes people with and without internet access prior to joining the panel. Internet access is provided to households that needed to participate. This is also not an opt-in panel. Members are recruited from an address-based sampling frame covering about 97% of US households. For the HRMS, we currently oversample based on income, race, and ethnicity and age to support estimates for key subgroups of interest. And in the WBNS, we have a large oversample of adults in households with low incomes. And we've also conducted separate oversamples of non-citizens and adults with young children that are not part of the survey's core sample, but that we've used to support analysis on special topics. Next slide. The cumulative response rate for both surveys is about 3 to 4%, which is low, but it's similar to response rates for random digit dial phone surveys. And this response rate is the product of the panel recruitment rate, the rate at which people who agree to participate complete a demographic profile for their household, and then the completion rate for our surveys, which is about 50 to 60%. Although the response rate is low, previous studies of panel recruitment for the knowledge panel have found little evidence of non-response bias for core demographic and socioeconomic measures. And we've also found that the HRMS and the WBNS produce estimates that are consistent with federal surveys that have larger sample sizes and higher response rates, and especially with regard to measuring changes over time. We create weights for both surveys that reflect the probability of selection from the panel and post-stratification to the characteristics of the non-elderly adult population based on benchmarks from federal surveys. Next slide. In terms of survey administration, panel members get an email invitation with a link to the survey, which they can take in English or Spanish. It takes a median of about 15 minutes to complete each survey. And even though these surveys are repeated cross sections, there's some overlap among panels across the survey rounds. Next. So now I'll turn it over to Steve, who will talk about the survey content and some of the key findings from the HRMS.
Thank you. So as Michael said, the HRMS was really born out of the Affordable Care Act. And so the content of the survey, there's a core that's allowing us to track health insurance coverage, healthcare access and affordability, self-reported health status, and family income, all key elements that are needed to really study the Affordable Care Act. But the survey also, because of its flexibility and the number of times a year that we had been doing it, allows us to add topical modules. And initially, the topical modules focused on ACA issues. We wanted to know how aware people were of this new policy, the ACA marketplaces and the subsidies, how aware they were as Medicaid work requirements came into play and what effect that might have on individuals, how well they understood health insurance. So we asked about health insurance literacy, patient trust in healthcare providers. As telehealth became more important during the pandemic, we were able to add questions about telehealth use and also perceptions of discrimination in healthcare. So we were really able to get a very comprehensive and flexible set of content around healthcare settings. Next slide, please. And for the WBNS, we had a slightly different focus. We were trying to look at the safety net more broadly. So not just health insurance coverage, but people's various dimensions of people's material hardship, their problems paying rent or mortgages, problems paying utility and medical bills, the extent to which they felt food insecure within their family, and whether there were unmet needs for medical care due to cost, which is also a question that overlaps with the HRMS. And I think one of the benefits of this survey structure is that it allowed us to ask about all these dimensions of material hardship, which had been touched on in other surveys, in one unified survey. In addition, we asked people about health and disability status, psychological distress, and to have this connection with health insurance coverage still. We asked about their employment characteristics, and again, about family income, and about the receipt of these various safety net benefits, whether it was SNAP, charitable food from food banks, Medicaid coverage, or rental assistance. But then, again, as we did with the topical modules in the HRMS, we had the ability to focus on some special topics within WBNS. And those were very much driven by policy issues coming up at the time of the survey. So when public charge came up in the Trump administration and those rules were changed, we asked immigrant families about their avoidance of public benefits due to these immigration concerns. We were able to focus on issues around participation in the 2020 census, the impact that gig work or precarious work schedules might have on individuals, how non-standard work arrangements where hours are not always predetermined could affect individuals. And then one of the things that we did just last year was look at the COVID-19 vaccine and attitudes towards COVID-19 vaccine. So there's a wide range of issues we've been able to touch. So now let me go to the next slide and talk about some findings. Next slide, please, from the HRMS. So this graph, which covers HRMS data from the beginning of the survey in 2013 to 2016, almost became, like, for the first few years of the HRMS, a trademark, where we looked at trends in health insurance coverage that were occurring during the implementation of the Affordable Care Act. And what this shows is that the Affordable Care Act had immediate impacts on coverage, both in states that chose to expand Medicaid as well as those that chose not to expand Medicaid. So between 2014 and 2015, coverage gains were quite substantial, but going towards 2016, coverage gains began to flatten out and not be as great as they were initially. Next slide, please. And you can see on this slide how those coverage gains translated into improved affordability for healthcare. There was a reduction in unmet need for care among parents, a reduction in families having problems paying medical bills, a reduction in families having problems paying for their children's medical bills, and an increase in the confidence that children could get needed healthcare when they get healthcare when they needed it. So you can see in this early period of the ACA, expanded coverage and improved affordability for healthcare. Next slide, please. But then, as we get later on into the HRMS, the pandemic hits. And we were supposed to go in the field the weekend after the economy shut down in March of 2020. We delayed the fielding of the survey, added a large number of questions that would help us track the potential impact of the pandemic. And we could see immediately what that effect was when we looked at the data from March and April of 2020. Over 40% of people lost jobs, work hours, or work-related income. And you can see that breaks down into those who were laid off from a job, were furloughed or reduced hours, or lost earnings. And that was one of the benefits of having the flexibility of the survey instrument. Next slide, please. And one of the great concerns about the job loss that was associated with the pandemic-induced recession is that with so many people having health insurance coverage through their employer, that there could be dramatic reductions in health insurance coverage. And in fact, what we found is that the number of people losing employer coverage between 2019, the year before the pandemic, and April 21, just a few months ago, was about 5.5 million people. But as it was different from previous recessions that didn't have an Affordable Care Act backing things up, the employer-based system gave, but public coverage, Medicaid, came in to fill a lot of those gaps in coverage. And as you can see, between 2019 and 2021, the number of uninsured remained about steady, which was quite different than what I think some people were predicting when the pandemic first hit. Next slide, please. Okay. But you can still see that even during the pandemic, independent of insurance coverage not being affected very much, people were worried about exposure to the coronavirus. And many people stayed away, delayed care, or did not get some type of care or multiple types of care. Some providers were also reluctant to see patients, and they limited their services. So what we found is that about 36% of adults either delayed or gave up having care because of the pandemic as of September of 2020. So the impacts on healthcare were quite disruptive. Next slide, please. And let me turn it back to Michael, who's going to talk about some of the findings from the WBNS.
Great, thanks. So I'm just going to highlight a few of the key analyses that we've done. So the first brief that we released using the December 2017 Wellbeing Survey data focused on material hardship among non-elderly adults. And for context, this was at a time when policymakers were considering budget cuts, work requirements, and other policies restricting access to programs like Medicaid, SNAP, and rental assistance. And so we were looking to provide baseline data on the share of adults who had difficulty paying for basic needs for their families, such as housing, utilities, food, and healthcare. And we found almost 40% of adults reported that their families had trouble meeting at least one of these needs in the past 12 months, including almost 1 in 4 experiencing food insecurity and about 1 in 10 who had problems paying the rent or mortgage. And so these results were surprising, especially the food insecurity estimates, which were higher than what's been found in federal survey estimates for roughly the same time period. And it showed that a lot of people were struggling, even when the economy was doing relatively well, and even among people, many people who were already working. Next slide. So those levels of hardship we found were very stable between 2017 and 2019. And then when the pandemic hit, we expected to see significant changes. But even though we found in our survey that about 9 million people lost jobs between December 2019 and 2020, we found that during the same time period, there were declines in the share of adults reporting hardship for that period. And so we think this likely reflects the substantial federal pandemic relief efforts that occurred early in the pandemic, including the stimulus payments, the expansion of unemployment benefits, the eviction moratorium, and other key changes to programs like a maintenance of effort requirement in Medicaid that kept many people on their health insurance during the pandemic. And we now know from federal data that these relief efforts coincided with a reduction in poverty during this time. So this chart shows that we found declines in food insecurity and problems paying utility bills and medical bills. But what's not shown in the chart is that this average overall decline concealed how many people who reported that their families lost jobs were still experiencing very high levels of hardship as of December 2020. Next slide. This chart focuses on another topic that we've paid close attention to, which was the Trump administration's effort to expand something called the public charge rule, which would have made it more difficult for immigrants to get green cards or temporary visas if they participated in federal health, nutrition, and housing programs. And so we found that in December 2018, about 1 in 7 adults who were immigrants or lived with an immigrant family member, and about 1 in 4 of those in families with lower incomes reported avoiding non-cash benefit programs because they were worried that it could affect a family member's immigration status. Next slide. So I want to briefly go over a few tips for using the data that are available in the public use files at ICPSR through the Health and Medical Care Archive. Currently, public use data are available for all rounds of the HRMS through 2019, and the March-April 2020 file will be available soon. The WBNS public use data for 2017 through 2019 are also currently posted on the ICPSR website. Next. So when you search for the data through the Health and Medical Care Archive, you can download the data documentation and user's guide by clicking the download link next to study level files. Next. And it'll take you to a downloadable guide which provides more information about the data and how to use it. And I'll just touch on some key points in the guide in the next few slides. So there are generally 3 types of variables in each file. One set are what we refer to as profile variables, which Ipsos collects from panel members when they join the panel and which are updated annually. These include key demographic measures like age, gender, race and ethnicity, and educational attainment. Next are the survey variables, which align with the question numbers in the survey instruments. And I just note that some of these variables are top-coded or suppressed to protect respondent confidentiality. And then finally, we provide a few constructed variables, mainly for those that are edited or imputed, such as family size and income and health insurance coverage status in the HRMS, and family size and composition, income and health insurance in the WBNS. Next. In both surveys, we impute missing data for family size and family income using a regression-based multiple imputation approach, which creates 5 sets of imputed values for those variables. And statistical software packages have special commands for estimation with the imputed data, like the MIEstimate commands in Stata. Next. The data sets also have, this should say, post-stratification weights to produce nationally representative estimates for the non-elderly adult population, as well as a cluster variable for variance estimation. You can use the survey options in statistical software to produce weighted estimates with accurate standard errors, such as the SVY commands in Stata. Each file also has a random unique identifier that's consistent across rounds within each survey. And last, some sensitive data are only available under a restricted access agreement with ICPSR. Next. So to wrap up, I'll talk about some conclusions that we've drawn from these projects and future work. Next. So in terms of lessons learned, we've learned that probability-based internet surveys like the HRMS and WBNS can provide timely data to inform policy and program implementation with survey results available within weeks to a couple months of data collection. Both the HRMS and WBNS have provided a flexible platform for informing rapidly changing policy debates in which we can quickly add or drop survey questions as new issues emerge. We've also found that estimated changes over time in key outcomes like health insurance coverage have generally been consistent with the patterns seen in federal surveys, which reinforces confidence in the estimates that we get from these quick turnaround surveys. At the same time, we've seen that respondents appear to be more likely to report some sensitive issues like food insecurity in internet surveys when compared to surveys that are administered by an interviewer either in person or over the phone. And this could reflect social desirability bias in which people are uncomfortable reporting certain things to an interviewer, or there could be other survey mode effects involved. In contrast to federal surveys, we found that the pandemic appeared to have a relatively limited effect on non-response rates in the HRMS and WBNS, perhaps because panel members had already agreed to participate in surveys when they joined the panel. But there are also some limitations to these surveys, which we've mentioned, including the low response rate, non-coverage of some populations, as well as small sample sizes for subgroup analysis. Next slide. In the near future, we're planning to use the 2021 WBNS to learn about changes in material hardship and well-being following the passage of the American Rescue Plan Act. This will include looking at people's experiences with the new advanced child tax credit payments. We're also going to focus on participation in school meals and other nutrition programs, among other topics. And then in the spring, the next round of the HRMS will have an expanded focus on health equity, including barriers to physical and behavioral healthcare access. Next. And so just to wrap up, you can find the HRMS and WBNS research products available on our website at urban.org. And if you have questions after the webinar about either of these surveys, you can reach me at the email provided here, mkarpman@urban.org. And turn it back to the moderator.
Well, thank you, Stephen and Michael. Really appreciate your time here. We're going to open up the floor for some Q&A. And it looks like we have a question. So, are the samples, the participants of HRMS 2020 and the coronavirus tracking survey the same? And also, will ICPSR get coronavirus tracking survey data sometime in the future?
So what we did with the tracking surveys was we started with the participants in the March-April 2020 HRMS, and we sampled a subset of roughly 4,000 of those participants, first in May of 2020, and then again in September 2020. And so we were able to look at some changes for those individuals over time across the 3 time periods, including for people who participated in one or both rounds of the tracking survey. We currently don't have plans to make the tracking survey data available as public use files. Because they're a little bit more complicated to analyze compared to the regular HRMS data.
Thank you, Michael. We will leave this up here for just a few more minutes in case anybody else has some lingering questions. All right, well, if there aren't any more questions, then I think we can wrap this up. Again, thank you to Michael and Stephen. Here's just a comment. Just wanted to say it was great to see such up-to-date findings and even from the pandemic. So not a question, but just a comment. Thank you so much for that comment. And I think we will go ahead and close up this webinar. Again, thank you to everybody who has attended. If you have any questions, please reach out to Michael, or you can even reach out to us at the Health and Medical Care Archive here at ICPSR. If you need anything, send us an email and we'll be happy to help you guys out. So I hope everybody has a wonderful rest of your day and take care.
Thank you.
Thank you.
Bye.